Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to the Voices of Otolaryngology. I am really excited to have Dr. Kara Meister with us. Friend, colleague. She has some great artwork back there, but she's going to tell us about herself. Dr. Meister, please introduce yourself to our audience of Voices of Otolaryngology.
Good morning. Thank you for having me. I'm Kara Meister. I'm a pediatric otolaryngologist at Stanford Children's, and I'm really excited to be here today to talk some about the impact of the environment on health, on otolaryngology, and on kids, some of my favorite things. So thank you for having me.
Awesome. I love it. Tell us a little bit about where you trained, maybe where you grew up, if you played any sports, anything fun. But we like to relate to our audience, to our members. Kara.
So I am from South Carolina. I grew up right outside, about 2.5 miles from a DuPont manufacturing plant. And my dad worked in a plastics manufacturing plant. And so a little bit of this is my Aaron Brockovich moment. I went to medical school in South Carolina, the Medical University of South Carolina. And it just really had great otolaryngology mentorship there. Trained in Pittsburgh for my residency in T32, and then have been at Stanford ever since. So I did pediatric fellowship there and have been there just shy of 10 years, which is wild.
Awesome. And I don't know if I missed it because I was still thinking about growing up 2.5 miles from a plastics plant, which is going to be an awesome discussion. Where'd you do your undergrad?
Clemson.
Oh, so fun.
Go Tigers. Yeah.
Yeah. And then you love the East Coast so much, you went as far away as possible.
That's right.
What drove you to the other coast?
Oh, it was time for a change, which, I thought would be a short-lived change. But if we're being totally honest, my husband was in California. So He's a Pittsburgh guy and had a great opportunity in California. And it was a win-win because it's a great place for my career to start. And
of course.
It's been a wonderful place for me to grow as well.
Yeah. For someone from Pittsburgh seeing the ocean, they're never leaving. Like he's there.
Right.
Yeah. We've got to answer this because it's going to distract me the whole time. Beautiful piece of artwork behind you. What is that?
Yeah. So embarrassingly, it was made with DALL-E. So it was made with generative AI, and it's supposed to be capturing the academic ladder. So one of the hats that I wear within our department is faculty mentorship. And so I work with a PhD colleague, Teresa Nicholson, to help faculty get to the next level, whatever that means for them. And so when we looked at our program we were putting together, it was just at the beginning of using generative AI. And this is one of the themes that it came up with as an illustration for that program. So
that is incredible. So just for the audience, I thought you meant Salvador Dali, but you mean DALL-E as in, can you describe it for the group? DALL-E is?
Sure. DALL-E is an generative AI platform that makes visual representations based on prompts and uses quite a bit of energy. So,
wow, that could be like me. Is it awkward to have you go a tad off screen and you can show us what it looks like? It's really amazing. I can see someone reaching for the ladder. Okay, what does the S stand for?
I think it must stand for surgeon.
Yes. Okay.
And then there's a little surgeon down below and a bigger one as well. So.
Yeah. What do you think that represents? Mentorship?
Mentorship. Yeah.
Awesome. Well, I love
Sponsorship, allyship, all the ships that we need to get us through this career.
Yeah. So one of the joys of my career is serving as your EVP CEO and getting to know the story behind people. I've known your pediatric otolaryngology career because we're contemporaries. And I attended a session which you were part of the panel at the academy. It was, I forget what day it was, but it was phenomenal. And as soon as you were done, I accosted you and begged you to join the Voices of Otolaryngology because I think our members need to learn about it. Can you talk a little bit about that panel and why we started off in jest, but in sincerity talking about growing up near a plastics plant?
Sure. So this panel, Little Patients, Big Impact, Climate, Health, and Sustainability in Pediatric Otolaryngology, I was fortunate to present alongside Patrick Kiesling, who's one of our star residents, who's very invested in this work, both in the basic science lab as well as community outreach and clinical research. Laurie Lalakea, who's a professor at Stanford, she was our chief at the Valley Medical Center, where she did really amazing supply chain work and has taken some of those findings and used them as a platform to get the eyes and ears of all types of stakeholders within otolaryngology, from the C-suite to patients to industry. As well as Duncan Meiklejohn, who's a Stanford alum. He's now the program director at University of New Mexico, and he's done a lot of work as well about what can we do as surgeons in the hospital to think about how we can impact supply chain and what choices we make in our daily lives. Duncan and I also work together looking at microplastics, which is adjacent to climate change in the fact that most microplastics are made out of fossil fuels, but not exactly what the topic of that presentation was. And so that's how it comes full circle. But we were really excited to present that panel. Thank you to the Academy for hosting it. And I think that this is a growing topic of interest for all of us. And so hopefully we can use today to share a little bit about the highlights and where we see this going next.
Yeah, thank you for that succinct summary of an awesome panel. I will start with, this is not about politics. It's about our patients. And I like to throw in fun little nuggets in these voices of otolaryngology. And I would say our members, this is just for me meeting thousands of them, are the whole spectrum of politics. And I'm sure you don't judge, I don't judge. We're half and half, whatever party you are. It's just really the whole spectrum. So Dr. Meister and I are not here talking about politics. We're just talking about how the environment impacts patients. What are some big takeaways from there? I had like 15 takeaways. It just blew me away. What should otolaryngologists across the world kind of be thinking about? Try to sum, and I'll help you get along. You don't have to give it all to us in 1 minute, but what are some of those big takeaways? Kind of the aha moment, like, oh my gosh, this really impacts patients.
Sure. So, thinking about the political charge, I think, this has become politically charged, but at its fundamental, it's really about health, right? It's about planetary health, and what's good for the planet is good for people, usually. Sometimes it's not the easiest choice. It's not the quickest choice, but that's kind of the ethos of my mentor, Steve Luby. That's how I approach this work. And so a question that we're often asked, and we actually had a slide in the panel, is, are we in our lane? Is this our lane, right? Like, who are we as otolaryngologists to talk about climate change and health? And really, especially as otolaryngologists, climate change affects otolaryngology health. We have the best data around allergic rhinitis, otitis media, and airway respiratory diseases. There's emerging data about sleep disordered breathing. We can go into some of that. But my first takeaway is, this is definitely our lane, because our charge is to take care of people, right? And to advocate for things that impact health, and specifically ENT health. The second big takeaway that I would leave with the audience is that healthcare is a pretty big culprit. There's many different statistics that you'll hear, but some of the more remarkable ones are that, if U.S. healthcare was its own country, we would rank 13th in the rankings of total greenhouse gas emissions. That's more than the UK as an entire country, which is quite impressive. And healthcare, we look at the global carbon emission footprint, healthcare is just under 30% of the contribution. We often think about things like cars and industry, but actually healthcare is a pretty big sector. Now, most of that emission is coming from energy. Generating enough energy to run our healthcare sector. And it really spans the whole gamut of healthcare. So we're not just thinking about, the operating room, we're thinking about pharmaceuticals, we're thinking about patients commuting to clinic. And so anywhere along the care continuum around the pipeline is an opportunity to enact change or to educate ourselves about just really the impact of healthcare on our climate.
Yeah, thank you for that. I think for today, both of those could be awesome podcasts, and maybe we'll do the healthcare one later. I'd love to focus in on those diagnoses. What was your aha moment? Usually it starts with the patient story, might have been your own children. I think you mentioned kiddos somewhere, but where did you realize the impact? I admittedly might be late to the game. I realized it learning from you and from your colleagues in New York who've done work on this as well. But what was your aha moment?
There were two, and they were pretty contemporary in timing. So we had several wildfires here as, in the 2020. There was the Camp Fire, and one of our residents, Patrick Kiesling, who was on this panel, he was on call, and he noticed that, wow, we seem to be getting a lot of just what we call mommy calls, people coming in
Is that
asking
the
about what we
Palisades
do.
fire, Kara?
These are the Northern California
Okay,
fires.
sorry
So
about that.
little,
Yep.
so yeah, previous to the Palisades fires, but a similar in impact.
Yeah, we love
And
those mommy calls. So what were the mommy calls?
the mommy calls were, what do we do? Can my kid go to their soccer game? Do we need to stay indoors? What we had school districts calling our pulmonary clinics. What do we do about PE class? And we had our residents triaging in the ED, and they were seeing more kids coming in with respiratory problems. And so Patrick Kiesling, one of our residents, actually did an amazing study that was serendipitous in the sense that he was able to look at air quality during the weeks of those fires, backtrack as a control of previous year. And luckily, we were able to show that there was low air quality, no problems with air quality during those weeks, and then looked at presentations. And he saw, most importantly, most markedly, a real uptick in croup. And as we think about the pediatric airway, we think about, those old laws from medical school where you think about resistance by diameter, and the child's airway is very vulnerable. And when it gets swollen, say from wildfire smoke or PM 2.5, we do see that inflammation, and our patients are coming in with croup. So that was definitely one aha moment. The second one, which I mentioned in the panel, is I have three kids. Anyone that knows me knows that I have three kids because I talk about them a lot.
How old are they, Dr. Meister?
They are one, almost two, 3, and 4.
Oh, my word.
Yeah.
I don't know whether to say sorry or congrats. It'll get better. I can tell you that.
So we moved for 6 months to a rental house. And in that house, there was a lot of carpet. It was an older house. It was meant for, a faculty temporary thing for Stanford employees while we did some work to our house. And there was gas in the kitchen. Basically, anything that you could look on a poster of poor indoor air quality was in this house. And my middle child could not sleep in this house. She could not go to sleep. She was stuffy. She was snotty. She had sleep disordered breathing. I was like, oh, here we go. Who's going to take her tonsils out?
It's always the middle child. I wouldn't blame the environment. I'd blame being the middle child.
There might be some truth to that. She is more feral than the rest of them, or spirited, as we say. And as soon as we moved back into our other environment, she was much better.
How much better? Like after 1 or 2 weeks? When did you?
After 1 or 2 weeks, she was 80% better.
Were you just like shocked?
I was shocked.
Did you make the causality, or you're like, whatever, she's better, I'm happy?
I was like, whatever, she's better, right? Because, I wasn't thinking too much about it. But right around that time, a group out of Brigham and Women's produced a paper looking at low-income families. They monitored air quality. They found that nearly 30% of them had air quality levels that were incongruent with what is recommended by the WHO. And there was a significant correlation with the poor indoor air quality and sleep disorder breathing. And so it just came out a few months ago, and it's one of the first studies where I think we're really going to see the impact of poor indoor air quality and how it affects the pediatric airway. And then, consequential to that, sleep disordered breathing and all of our other respiratory and aeroallergen types of disorders. So
when did you
that was a huge
connection for your daughter once you were in the different place after 2 weeks? When did it click to you like, oh my gosh, it must have been the environment?
It was really as Patrick and I were preparing for another talk, and I came across this paper, and I thought, hey, this is what I see. Since then, that was about 6 to 9 months ago. Since then, I've been advocating to a lot of parents, hey, make sure you have an air filter in your house, right? Great. If you have a PM 2.5 filter, they want to know, what can we do, doctor, besides just taking out their adenoids? What can we do besides tonsillectomy?
What do you mean? Do I put that for my HVAC or do I go buy something?
So there are many different strategies. I think the most important thing to consider is we're really looking to get to that level 2.5. So particulate matter 2.5 microns is where the data is showing that.
So I have no idea what you're talking about. I know the size of a golf ball and a baseball. What is particulate matter 2.5? You're rattling it off. Can you explain that for our audience?
Sure. So particulate matter 2.5 is just it's a size measurement, right? So 2.5 microns as a size. And usually these are things like dust, polyester, chemicals, things that can be burned. So we see a lot of it in wildfire smoke. A PM 2.5 filter is meant to get to that level.
Why are you using the word 2.5? Is that a certain micron size that affects the airways, or is that an industry standard?
It's an industry standard, and it's where the data for airway health comes from.
Please talk about that. Do you mind a little bit for our audience?
So we think about 2.5 as really, if you want to put in perspective, it's about 30 times smaller than a piece of human hair.
Okay,
and we think that can get deep into your body, right? So you breathe it in, most likely. We can talk about ingestion probably at a later date. But our thought is that when you get that small, you can create systemic and local inflammation.
Perfect.
So we're thinking about things like gets into your lungs, it gets into your bloodstream, and that can affect how your body is reacting to your environment.
Yeah.
PM 2.5 got really sexy during wildfire because it is a huge component of wildfire smoke. It's also in other things like cigarette smoke and indoor air pollution. So things like your gas stove, dust mites, laundry, these types of things.
So that's where the 2.5 came to us, especially as otolaryngologists. Like, really, we should understand that because we are airway experts from nose to bronchi. So 2.5, let's take a little commercial and talk a little bit about it. So when you talk about air filters, so do you recommend that? You said you would have had an air filter. Talk to our members about this. Should they counsel patients? Where do they send the patients? How do they manage a patient when they start thinking about environmental impact and getting an air filter?
Sure. So there are a lot of commercial air filters. Say Dyson has one, right? That's kind of, it's something that you can buy as an everyday consumer. And what you want to do is you want to say, look at that 2.5 and make sure that you're going down. Some will only go to 10 microns or say 5 microns. But we really want you to, if their patient has the resources, get to 2.5. So there are commercial ones where I counsel my patients is if you can have it in the bedroom, that's probably going to help. The other thing that I will counsel patients is if bedroom isn't an option, the laundry room may be a next best step because we bring in a lot of allergens, a lot of pollution on our clothes. And we also actually create a lot of particulate when we wash and dry our clothes, especially things like polyester and nylon. Many homes in the Bay Area, the laundry is actually outside. And so that's less applicable, but if there's laundry in the home, that's an option. Many washers and dryers are actually putting these types of filters inside, and that's actually the standard in the European Union is to have these types of filters within the washers and dryers that are that you're using residentially. We I was going to say at Stanford, we also have created some patient handouts, and we'd be happy to share those with any of the listeners of how to make your own air filter. It's not going to go down to the level of 2.5, but if we are in a setting where there's wildfire smoke, it may well get us to that 10 micron level, which is probably better than nothing. And these are very user-friendly, like make your own air filter at home types of handouts.
So I'm going to, I don't mean to put you on the spot if you're not, but I presume you're board certified. You're board certified? Good. So we are both
for otolaryngology and pediatric otolaryngology.
Yes, we are both board certified and we're fellowship trained. And let's talk about your daughter. So came to my office, 6 months of rhinorrhea, nasal congestion, nasal obstructed breathing. I would probably do a nasal steroid, depending on our age, for 2 to 3 months, see efficacy come back, and I probably then would think about adenoidectomy. You don't have to agree with me, but that's kind of your algorithm, maybe before. But now, have you changed your algorithm? I honestly, before attending your panel, wouldn't ask about too much environmental. All right. I'm not as good as a doc as you are. So now, do you ask that? Do you screen it? Where do you start thinking about it? And how does it impact? Let's take your daughter's vignette there.
Sure. So I do think about it. It fits into my algorithm, but I'm not sure that it's changed it. So my typical approach is my first meeting with the family. I want to know, did the child have eczema as an infant? Do they have asthma or reactive airway disease? And do you have a strong family history of environmental allergies or food allergies? And what I'm trying to get at it there is, how atopic are they, right? It seems to be, there's no data to support this, but it seems to be that our children who are more atopic oriented tend to react more to these environmental exposures, right? As I explain it to parents, we have great allergy panels, but they're not comprehensive of the 80,000 exposures that we come across every single day, right? And so I think I ask that as part of my history. In those families where they're either very motivated to try non-surgical management, I also do nasal corticosteroids. I like Sensimus the best, fluticasone furoate, and nasal saline. I also counsel them on putting an air purifier in the bedroom, if that's a resource that they can do, as well as just thinking a little bit about their exposures. For example, if I have a soccer player who's playing outside on ryegrass all day and he seems to be more atopic, I'll say, hey, take that jersey off. Don't jump on your bed, like change your clothes, right? Jump in the shower, rinse all this stuff off, like as much as you can control your environment. And I would say probably 10% of my patients anecdotally, they come back and they're like, doc, I'm better. And they can come off their steroid and life is good. So I use it as an adjunct, and I do think it makes an impact in certain patients. Has it ever avoided surgery? Maybe for a handful. I don't know that I see those patients back to really have that full data set. But I can tell you it made a huge difference in my daughter when we changed her environment.
Yeah, I hate extrapolating from an N of one, but these pearls are amazing. You are such a thorough, great doctor. We should kind of set up a referral, like you see them medically and send them to me for all the surgeries. I mean, those are awesome, awesome questions. I'm thinking of my son's baseball team, right? When all 20 of them come into our basement in their uniforms. And I know it's gross, right? And I never thought about that. They've been outside for 8 hours in there and they're just sitting on the carpet. Then what happens? So interesting, very interesting. And it literally took you 1 minute to explain that to a patient. It's not like a 30-minute soliloquy.
Yeah, and so we know that our environment influences our long-term health, right? Just look at things like peanut, right? We took peanut out of our environment because we were afraid of anaphylaxis, and we ended up with more peanut allergies, right? Kids who grow up with a dog in the home tend to have less allergies because they are exposed to dirt. So you need some of this, right? You need that exposure. It's just when it's in excess or when it doesn't jive with your body, I think that is the difference. So I don't think that everyone needs to live in a bubble. And certainly we don't want 20 baseball players throwing away their muddy clothes all over your basement. But if there's a child on that team who has a really bad grass allergy, something to think about for them.
Yeah, really interesting. You talked about 3 kiddos. You mentioned a spouse. Any pets in the Meister home?
Oh, totally.
I knew it.
Dog.
You're one of those happy, self-inflicted wound pediatric otolaryngologists with 3 children. What pets do we have?
She's a half Australian Shepherd, half poodle. She is our toughest child. She's so spoiled.
Yeah, I can imagine. God bless you. There's 4 little ones in there. So you mentioned allergic rhinitis, otitis media, airway, and potentially sleep.
Mm-hmm.
Help us guide our listeners who are usually split, half private practice, half academicians. You mentioned a great, I don't want to use the word algorithm, but how you weave in the discussion in your intake, how your medical assistant can do that. What else are you seeing? You mentioned the Brigham study, the other studies. I love that. What should our otolaryngologists be thinking? So you've already changed my mind now. I'm in the office 2 Fridays from now on the 23rd. So I'm going to start asking about, I like how you said, it's more the A to P. It's not just like jumping on, specific stuff. How else should we weave it into our practice and kind of other specific diagnoses you've seen or thought about?
When right after we had some flooding in Northern California a few years ago, an amazing rainy season. It was beautiful, but it made a ton of pollen, right? And then we were seeing in our clinics more and more kids and adolescents, and even the parents of those children coming in and saying, I've never had allergies and I have all this stuff. I now have rhinitis, my nose is draining, et cetera. And so the one thing I would say is kind of a clinical pearl is we often think of things like allergic rhinitis as being binary. You either have it or you don't. And I think it's more on a spectrum. I think if you get someone around enough exposure to something, you can irritate their nose, right? And so I tend to think about it that way. I tell patients, if you're out all day and you're hiking and it's been a bad pollen season, think about nasal saline. Think about just rinsing your nose. You rinse your hair, you rinse the oil out of your hair, just get that stuff moving through your system. And they'll say, but doc, I don't have allergies. And, then we have the discussion of, even if you don't have allergies, your body's going to react to something that it sees. The data around allergic rhinitis is fascinating. It is exponentially increasing to a level that is, it's more likely to be a true incidence increase than a diagnosis bias, right? And so what we think is that because of climate change and because of changes in air quality, there's some data that those actual air allergens are picking up our chemicals in the air, and they look different to our immune system, and they are heavier, so they're harder to get out of your body, which I think is fascinating. They're more pro-inflammatory. And also with climate change, we are getting increased pollen counts. And so people who kind of flew under the radar are now at a threshold that's pathologic for them. And so I think just thinking about what you see in your local environment and how that might be affecting just the community at whole is also, it's been a really fascinating part of medicine because we all complain about a nasal congestion in a 4-year-old, but this just adds a lot of depth to what I see. Yeah.
I just take out the adenoids. No, I'm just kidding. I promise. My reputation, Kara. I'm just kidding. I'm very conservative, but I really like that nasal saline idea. So I really hadn't thought about that. Very cool. Otitis media, you mentioned a little bit. Do you want to rattle off? You and I see that probably every other patient. But I'm trying to think this through. Yeah, talk to me through the environmental impact on otitis media. And you mentioned Pittsburgh, so you're continuing the fine legacy of otitis media coming out of Pittsburgh, right?
Yes. So the otitis media literature is a little bit softer. It's not as robust as allergic rhinitis. But one study that I think is truly interesting was looking at prenatal exposure, right? And so this is in utero exposure to PM 2.5 and nitrous oxide in a large cohort study of about 9,000.
Hold on, who gets exposed to nitrous oxide? It seems like anesthesiologists and surgeons.
That's right.
Who gets nitrous? We get nitrous in the environment?
We get nitrous in the environment.
Seriously, I'm not.
It's a greenhouse gas.
Yeah, I'm not making fun of you, but where are certain areas that where would a mom be exposed to nitrous?
Just in any urban environment, you're going to have some nitrous oxide.
Really? So in Alexandria, if I look outside, the concentration of nitrous oxide is higher than in the California mountains.
Oh my gosh, I have no idea, but I would guess, given that it's more of an industrial byproduct.
Thank you. Yeah, great. Yeah. So the study, 9,000 patients exposed to PM 2.5 and nitrous oxide.
In utero, right? So these are prenatal exposures, right? And certain in utero exposure to PM 2.5, especially in the mid-gestation window, as well as PM 10. were associated with a higher incidence of childhood otitis media. Now, that is not causal, right? It could be that prenatal exposure meant that they were born into an area of higher postnatal exposure. It could be that there's some epigenetic modification. It could be that, their immune education is just different. But it's a pretty big group of 9,000 kids, and they are seeing this prenatal exposure. And we think that that early immune education, when the mom has immune tolerance to the fetus, probably does have lifelong immune impact on the child. And so I think this is an interesting study in the sense that it's really the tip of the iceberg. It's a completely undiscovered field of what our in utero exposures doing to our health and how our immune system functions.
Yeah, thank you. I told you I'm a little bit off kilter at times. This is an Academy Oto Journal pen. So I encourage anybody who's a scientist or writer or clinician, remember, publish all your stuff in our journal. So you mentioned PM10. So I got PM 2.5. What are PM10s and what are the implications of that? If you could just educate us a little bit.
Sure. So PM10 is going to be it's a heavier micron size. So instead of 2.5 microns, we're talking about 10 microns. Also a marker of air pollution. When we think about PM10, that's pretty big as far as particulate size goes. Likely not going to get intracellular. So you're thinking more macro disruption.
So it's not a golf ball. It's smaller than a golf ball.
Smaller than a golf ball.
So yeah. PM10 microns. Can I see it?
You can see it. Yeah, you should be able to see that on a filter. Yeah.
But like with your own eyes, you can see that.
You know how sometimes if you shake out your shirt and you look in the sun and you can see it through the sunbeam?
You said something interesting about the wildfires. So I'm going to tell you a little vignette and then you'll make it clinically relevant. So out here in DC, we had the impact from the Canadian wildfires. No reason for you to know that, but it came down and my son's baseball practice was canceled. And I was so angry. I thought everybody was weak and losers and they couldn't be out there until I attended your panel. And I was super embarrassed because sometimes the coaches, might be the only doctor on the team. They're like, what do you think, doc? I'm like, yeah, you should be out there playing. I was really embarrassed because there was like a smoke warning in the area. And so I got nervous.
Yeah.
Shame on me, but your panel opened up my eyes about how to think about how we guide our patients with those environmental factors. Can you talk a little bit about that?
Sure. So I think that for many patients, for many children, you're absolutely right. It's fine to be out there. But for those children who have any reactive airway disease, who may have a smaller trachea or more prone to croup, I would say for kids under 5 years old, they're more vulnerable to the effects of wildfire smoke for air quality, right? So,
and it was not a normal day, Kara. It was like a red alert. They shut all county activities, and then I said, "Oh, the fields are open." Oh no, it was not a normal day. So
yeah,
keep going.
probably
what you're saying?
Stay indoors. Yeah,
right. But that's a hard thing to understand. So, right. But keep going. You're doing great. So stay indoors because.
Yeah, but just because children are more vulnerable, right? So they are, their airway is smaller to start with. They tend to have more reactive physiology. And, it's always about risk versus benefit, right? So there is the risk of being out there and worsening someone's asthma or precipitating some type of event. Is it worth a week or so of baseball practice? I don't know. I guess it depends on the ethos of your team, but
exactly, Kara, that's what I told him. Like, we're not going to have a winning record if you keep missing practice. I love it. So you just said that too, Doc. You said get out there.
Yeah, it's.
Why did you say a week? Again, it's phenomenal. You look at life so differently. I was so angry they missed an hour of practice that once, I don't know, a little bit later, I sent them outside. So it impacts the kids for quite a while.
Yeah, it impacts the kids for quite a while. Yeah. And so, and we don't know, like, what is your clearance of that, of those substances, right? So that's one thing we don't know.
Talk a little bit about that. Yeah, talk about
Okay, you go into a PM 2.5 chamber, right? And you breathe the stuff in. For how long is it going to be either one, still within you on the macro scale, or two, its effects, subsequent? I think one of the things about that prenatal exposure literature is there seems to be some actual true modification. Now, granted, that was prolonged exposure in a period of time wherein your immune system is different than it is during a normal physiology. But I think that there may be more long-lasting side effects than we know about. And we just don't know how long this stays in the body.
So just a couple more questions, because I could monopolize your insight. And I'm starting to realize I'm not such a good doctor. I've completely missed this part. You insinuated a little bit airway and sleep. You don't have to quote me stuff, but talk to me a little bit about it. And we don't have to even talk about your daughter, but you mentioned she was having sleep disturbances. But are you seeing studies or abstracts or posters out there in other countries or here on a macro level that there's an impact to that?
We really only have the first big paper is this 2.5 indoor air quality from the group was around 300 children outside of the Boston area, but I do anticipate that we're going to see more data coming out around this. And, physiologically it makes sense, right? If you are more of an atopic person, you're a 2 to 3 year old whose adenoids are already a little enlarged because that's their job. Kids are exposed to viruses. They live near the floor. They're picking up dirt. They don't have great hand hygiene. It's normal that their tonsils and adenoids are a little bit big, right? But then you throw on top of that their environment, and they're totally pummeled by insult from their own environment. And, now you have a mismatch between the size of their little body and the size of that immune tissue. And so I think that, to me, that's more hypertrophy and mucosal inflammation. They have very little wiggle room to start with. You put this on top of it and boom, there you go. Now you've got sleep disordered breathing from an obstructive standpoint. So,
what are you working on these days? Not just you, but your colleagues. You mentioned your trainee, Dr. Patrick. You mentioned other collaborators. You can talk about yourself or the field in general. Where are we looking at, or where are you looking at now?
Sure. So I think there are 3 kind of areas that we are focusing on, the collective we. So within my lab, Patrick Kiesling and our clinical research coordinator, Andrea Miranda, who's been with me for, almost 6 years now. She's an amazing resource. They are doing a good bit of community advocacy work. So we know another wildfire is coming. We know that cycles of poor air quality is coming. How do we proactively get this information out, right, to the communities that need it in the format that is accessible to them? And so they've been working with some of our local Hispanic health groups and doing boots on the ground advocacy, as well as having those resources vetted and ready to go within our electronic medical record for when this does happen. So community outreach and engagement is
Kara, are you going to use my favorite 2 words, AI and innovation? I mean, it seems like you all could create tools. You could have alerts go out there that we see on our phones. I love that you're doing boots on the ground. That's awesome.
Yeah. So we'll use AI and integration. I think that's a different area where we can maximize the use. And what I mean by that is we have so much data, right? We have all of these learning health systems that are coming online. We have Epic Cosmos. We are getting better and better community level data. And so, as a surgeon scientist, we've always thought about discovery as you start in the lab, you have this question, you do it in this very controlled model, and then you go out and you take that drug that you've created in the lab and you test it in people, and most of the time it fails, and then you go back to the lab and you iterate, right? I think that with AI and with the amount of sheer data that we have, that is changing. We can ask these big questions with messy data because we have so much data and the tools to mine them. We can find the answer and then we can prove it in the lab. And so kind of that backwards flow, I think, is where AI is really going to help us to answer these huge questions that are just impossible to control for in the lab setting.
And I didn't mean to sidetrack you. Yeah, I didn't mean to sidetrack you with my personal philosophies, but so community.
That's usually the third thing. So I say community outreach. Yeah.
Right.
And then I say what we're working on in the lab is really focused on microplastics. And we use human tonsils from patients to both grow model systems as well as to study the microplastics in those tissues. And spoiler alert, 100% of the pediatric tonsils we've studied have microplastics in them. Whether they are causing harm,
no way.
No.
And you just gave me a crazy nugget.
Yeah. Unpublished data. We'll be looking for a home soon once the stuff is there.
Here, submit it to the Dr. Schmalbach's, the editor. I don't know how much you can tell us. That's insane. Like in medicine, it's never 0 or 100%. But what you're saying makes a lot of sense. But so why, again, excuse the ignorance, but I'm going to ask it, why do I care? Why do I care that 100% of tonsils have microplastics? What does that mean?
We don't know what it means, right? It may just be that they are innocent bystanders. They're not affecting us at all. The question that we're really trying to answer in the lab now is, without going too far into the weeds, is whether or not our antigen-presenting cells actually present plastic, right? And what the mechanism is. Because if that's actually happening, then we may have a mechanism to think about them influencing our immune system and how our immune system functions. So that's kind of the second thing. And then the third thing is...
hold on just a second. You're so wicked smart. I have no idea what you said, but my head is getting it. That is super cool. How does your lab do this? How are they looking at what the APC is putting out there? That's so cool. What are the methodologies?
So we use organoids. So we grow tonsils from patients. So the advantage of that is they have some genetic diversity to them. And then we study both the outputs of those tonsils after exposure to plastics. So looking at things like Th2 responses, what you can infer about the MHC complexes. We're going way back now to basic immunology, as well as some pretty slick imaging tools that we have on campus. So
I think that's
what we're working on.
That's crazy, Kara. Could you grow me a new brain when you're done with the tonsils? That is super, super cool. And I interrupted you. You were talking about something else in your lab, and I interrupted you because I got excited about
No, just say. And then number 3 is really just challenging ourselves to think about data and science in a different way, because we have a whole new set of tools, right, to answer some of these population-based longitudinal exposure questions, which is exactly what planetary health is. And we're really thinking about how do we use AI and to mine, collect, and understand these data in a way that we've never been able to do before. And so I think it's really flipping the scientific method on its head a little bit. And I'm excited to see what we can learn.
Yeah, I want to acknowledge all your collaborators, because you said, I don't want to do a podcast myself because I represent all these great people. You mentioned Patrick, I believe Andrea from your lab, Andrea.
Yeah.
If that's right. So you mentioned all those collaborators. So I want to be clear. That was Dr. Meister's ask, and I said no, but anybody that I've forgotten you to shout out, by all means.
Yeah, I would say my mentors and collaborators in this space, Laurie Lalakea and Duncan Nicholjohn. So if anyone's actually looking for a true patient-facing expert, they're your go-to people there. And so very happy that they'll be putting in a sustainability module for core curriculum. Both of those individuals are doing a lot with their respective schools of medicine for educating our medical students, which is now a part of the curriculum at Stanford, and for our otolaryngology residents through the OCC, as well as educational content for our general membership through the sustainability task force.
Thank you for shouting out the otolaryngology core curriculum as we keep it contemporary. That was none of this was rehearsed. Everybody knows. I just make it up as we go. When did you finish fellowship, if I may ask?
I finished in 2018.
Kara, we're not contemporaries. One of us is a titch older than the other. I finished in 2006. So 2018, and we're now at 2026, right? Mm-hmm. All right. So that's a phenomenal career progression in 8 years. And this is not rehearsed. I'm just super impressed. How did that happen? How do you have time to be a surgeon scientist and operate? What advice would you give to those that are finishing fellowship early in their career? That's a phenomenal 8-year rise. Congratulations on that.
Thank you. I would say that your family is incredibly important. I mean that both by my personal family. I have an incredibly supportive husband. I have kids that sleep, which is helpful. But also my work family is amazing. So our department is very supportive. It gives people the opportunity and resources to do. And then I have a great mentor in Alan Chang. He's our division chief, who's been my mentor since I was a fellow at Stanford, and partners that are willing to, hey, I need to do this panel. Can you cover my call? Hey, we help each other out, and it's a really professionally safe area. So I'm so thankful to be a part of our division that kind of gives us all the opportunity to do whatever it is. And so I think just choose your family as much as you can, your work family and your home family, and then find something that's exciting, right? Find something that's really fun, and then it's not work anymore. So I still can't believe I get to operate. I love my tubes and tonsils days as much as my big head and neck days. And I love being in the lab. Those are definitely my intellectually challenging days, is to be in the lab. And I really think one of the things about being an otolaryngologist is our day-to-day is so varied, right? Whether that's clinic versus OR, or whether I'm filling a role with some of my academy and leadership work, or working in the lab. It's just an amazing career where you get to do something different every day, and that's really fun. I think it keeps us all excited and engaged.
Yeah, I love that I get to know people like you. You can count me in your family there, because having a student like you is so easy. We just sit back and you just shine. You make our specialty look better. So I'm sure your mentors love having a great student. 2 more questions, I promise. This could go on forever, because I think you're really educating us on things that we didn't learn. And since I know that you and I are almost a generation apart, we just didn't learn some of this. So I'm learning as we go. 2 more questions, I promise. You grew up 2.5 miles from a plastics plant. When were you like, that's interesting? And maybe it's now. I don't know. I'm just curious.
Yeah, I think it's now. I remember.
And it might be fine. I don't know. I'm just like, when did you ask yourself?
Yeah, I think that I have distinct memory of, when I was young, my parents shared a queen bed. And if you looked on where my mom slept versus where my dad slept, it was black. I mean, he would get home, he would take a shower, and he would get.
What did your father do, Kara?
He was a mechanic in the plastics plant.
Wow. And your mother?
Yeah. My mother was a special education teacher.
So. Okay. So you noticed, I guess that's PM10s.
Probably PM10, some type of, and polymers and all other types of industrial waste, but it was kind of ingrained in him. So
then
I remember that as a very distinct memory.
Yeah. But then when did you say,
this is interesting. I think it was honestly living in California. So my patients asked the questions. What about all these plastics? What is this wildfire smoke doing to us?
Then you started connecting.
This seems to be a super bloom of pollen. And then I started thinking, I have a real interest in our environment and what it's doing to our health. So,
are they still live there?
Both my parents passed from cancer when I was younger. So.
Yeah, I'm sorry to hear that. Yeah, thank you. It's certainly where our passion comes from. So proud of what you're doing. It's incredible, Kara. All right, what can we do? So this is one of our coolest podcasts. It might be one of our longest because you're that good. What can I do? I'm an otolaryngologist in a private practice setting. You've already educated me on thinking about A to P environmental factors. I just love your honesty. I don't need to slip in an allergic eval in my algorithm for adenoidectomy, but you're just raising awareness. Give me some pearls. Give me a couple though. Don't overwhelm me because I'm learning. So give me a couple things I should do tomorrow that I should think about as an otolaryngologist. We'll have a separate one on healthcare because this was super fun, but vis-a-vis diagnoses and patients.
Yeah. So I would say just ask if they are more atopically oriented. That's number one. Probably even before that, maybe that's getting ahead of ourselves. It's just find something that's of interest and give it a read, right? Really just take half an hour, find a paper or two, bonus points if it comes from the white journal, but just to do a little bit of investigating and see if this is something that's sparks your curiosity. I think if it does, it's easier to talk to patients about it, right? And then just pay attention, keep our eyes open, because right now we're talking about, air quality and climate and change, but we don't know what's next, right? We don't know all of the things that are influencing our health. And, this is something I'm passionate about, but I really encourage our trainees to approach their clinical care with new eyes and fresh questions, right? So I think that's number one, is just staying curious. Number two is asking about environmental exposure. Hey, do you have an air purifier at home? Would you be willing to try that? That type of thing. It can be very, very beneficial. And then number three is if you're interested in any of this work at all, and how we as healthcare providers are contributing and can not contribute to greenhouse gas emissions, feel free to reach out. There's also a good bit of material on the Academy website. So.
Amazing. A little plug. When was your session at the annual meeting? Because if you attend the annual meeting, you get a webcast. And so people can hear the whole presentation from the panel, which sparked my interest. I love your point about go read something. What day was it in Indianapolis? Do you remember?
It was the last day, the last panel.
Tuesday. That's why I was there.
Tuesday. Yeah.
And remember, I promised you that they're all recorded so people can go back and listen to it, because I thought it was phenomenal. And what was the title of that panel again?
It was Little People, Big Impact,
And
Climate, Health, and Sustainability in Pediatric Otolaryngology.
All right. Yep. You guys got that. And then Dr. Meister, you can search for her name and find that webcast. But it was, of course, a panel. There were several of you on it. This was absolutely amazing. I'm going to give you a final word. Anything you want to shout out?
Thanks for having me. I really appreciate it.
Amazing. Thank you so much.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.